Well, good morning from Cleveland Clinic here in Cleveland. It's cold and snowy. I'm hoping that many of you are also in warmer climates than us. And this morning, we're going to try and address the question of why does Cleveland Clinic deliver such superb outcomes? And it'd be nice to say that we have one single key to turn to success, but that's not the case. It is many, many years of work building on our founders. We are celebrating 100 years this year of the success of the Cleveland Clinic model. And each subsequent generation, including all of us here, have built on the shoulders of previous giants, as the Newtonian saying goes, but for many of us surgeons, we've looked over the shoulders of giants. So a couple of things about a model that I think are important. The one is that everybody's on a salary. And that's important because we do what we believe is best for our patients. And that allows us a lot of freedom in taking care of our patients. And we don't have any restrictions as far as what we do, what we believe is best for our patients. Secondly, we have a very strong emphasis on quality and research and outcomes research. In other words, looking for ways to treat our patients even better. And that's part of our mission. And thirdly, education of our forthcoming generations and leaders is very much part of our fiber as an institution. And all of us have, to some extent, been parts of that process of learning at the Cleveland Clinic, and we are very much involved in developing the next generation of leaders. So those are some overviews of the structure of the Cleveland Clinic. Our results are superb. Marc Gillinov will talk a bit about cardiothoracic surgery, and for example, we haven't had a death of the mitral valve repair surgery, including with robots, which is over 2,000 patients now, since 2014 of September. We have gone several years with aortic valve, isolated aortic valve replacement without a death, but recently had one. Our percutaneous valve program, one of the first of three in the United States, now called Davalla or TAVI internationally, has had superb results. Last year, we had a couple of deaths, close to 700 patients. The year before, just under 700 patients with no deaths. Our vascular surgery program is one of the leading programs. Our percutaneous coronary intervention program runs in the 95th percentile best in the country. Our thoracic surgery program, as far as we know, is the only program that has STS stars of 3 each for each program. So with that, I'm going to ask each of our leaders to summarize and briefly talk about their departments or sections that they lead. And starting off, I'm going to ask Samir Kapadia to talk about cardiovascular medicine, and he'll be followed by Leslie Cho. Samir is a well-recognized leader in cardiology area and in particularly structural heart disease. He has led many of our research studies and is the department chair of cardiovascular medicine. And that's a very big group of cardiologists, about 140, 150 cardiologists, and I believe the biggest in the United States. So with that, Samir, what's the key to success at the Cleveland Clinic?
So first of all, thank you, Dr. Svensson, for the kind introduction. And I agree that this is the largest department, not only in the United States, but in the whole world, because 150 cardiologists to work in one place is very unique. The most important feature for our department is that each cardiologist is passionate about what they do. They are expert in their specialty. They want to be not just something that follow the literature, but write the literature. So these are the people who are forming the path, the new way of doing things, and each of the departments, each of the subspecialties. And this include our electrophysiology, our interventional cardiology, preventive cardiology, clinical cardiology. So we have 8 sections, imaging, and each of these 8 sections is led by a section head, and each of them have about 15 people inside of each section. All of these cardiologists work every day in the clinical practice, but still they do research. So this is very unique compared to any other institution where some people do research, some people do clinical work. Here, everybody does innovative work, and at the same time, they contribute to clinical practice at the highest level. This provides the clinical structure in a way that people are really experts at what they are doing. And this is, I think, one of the most important reasons why our quality is so outstanding, because these leaders are not just thinking about new things, doing research, but also seeing patients at the same time at a very, very high volume and at the same and passionately. Myself and all other people who are here are working every day in the clinical practice, despite having a lot of administrative roles and a lot of clinical research that we want to do. And we are passionate about each of these fields. We monitor our quality, and Dr. Cho is our quality officer, and she is going to describe how we do this. But every year, we monitor not just yearly projects, but every day we monitor the quality. Every month, we report to the physicians that how they are doing, and if there is a problem, we work as a team. So this is another very important part, that everybody works as a team. As Dr. Svensson mentioned, we are all financially, we don't have any other interest. We are all working together as a team. So whatever is the best approach for the patient, and in many patients, more than one physicians are scrubbed in the procedure, more than one physician gives an opinion that what is the best thing to do. So this is another reason why we are very unique, and we are able to provide this kind of care, which is world class compared to anywhere in the world. And the last thing is that we are not just working in Cleveland Clinic, but we are collaborating to the entire world. We are not competing with people because we have nothing much to prove or anything like that. We want to learn more. We want to provide the best care. So whenever opportunity comes, we are always collaborative with all the thought leaders in the world, and we work as a team. So when people come to Cleveland Clinic from a long distance, they are not just getting an opinion of one person, but the best opinion in the world that is possible, because we are connected with all the thought leaders and we are friends with them, and they all consider us as their colleagues. So this is another very important piece that I think we should highlight, that this is a very unique place in that respect.
Thank you, Samir. So Samir highlighted the importance of teams, and that's something that we work very closely together. And we often discuss cases among ourselves, that is, among the physicians. And for example, Samir and I virtually daily talk about care of patients. So there's this great team spirit where we work together. All right, I'm going to ask Leslie Cho, who's our Director for Quality and HVTI, to give her input on what she thinks the reasons for the great success of the Cleveland Clinic. Thank you, Leslie.
Thank you, Lars. I think Dr. Kapadia has put very nicely, and Dr. Svensson, about the long history of this place in terms of its importance that it is placed on quality. I think the one really great thing that we do is that we review all our deaths, we review all our bad outcomes, and I think we learn from that. We really believe in that sort of reiterative learning process, and not as a punitive way, but really just to learn and to get better. And I think that kind of constant review makes us better as a individual, not just individually, but as a group. And that review actually makes us highly reliable. So whether you're the first cabbage of the year or whether you're the last open heart surgery of the year, which is 5,000, you get similar cases because review per week, per month, per quarter. And I think that's really important. The other thing we do is that we really believe in quality control, whether we, not just for our interventions, but for our imaging studies. So 10% of all our imaging studies gets reviewed by a blinded reviewer. I mean, it takes a huge amount of effort, and there is no outside vendor that's looking in, but it's our mechanisms to make ourselves better. And I think to bring on new staff and to bring them up to the Cleveland Clinic way, this is one really good mechanism that we have. And I think the last thing is that we're very collaborative. Whether they're surgeons or interventionalists or clinical cardiologists, it's an incredibly collaborative group. And I think that's another big success, a factor to our success.
Thank you, Lizzie. So thanks for emphasizing the point that, we are very careful and looking at all our deaths, all our outcomes, and trying to improve them. And we have, as the term is used nowadays, psychological safety. We think it's very important in this environment that people have security when we are discussing bad outcomes. And all of us have a bad outcome at some stage. And we have a very open discussion about that. And then the team gets together on looking, how can we make things better? Is there a problem with our process? Is there a problem with our structure, our backup? And that's actually not often the case. So thank you for highlighting that.
Thank you.
All right, so our next person is Marc Gillinov, a world-famous cardiac surgeon. And Marc is chairman of Cardiothoracic Surgery. And as Leslie mentioned, we do about 4,500 heart operations here on main campus, a bit lower now with the pandemics, but well over 4,000. And then with our regional hospitals, we are just under 5,000 heart operations. If you look at our whole system, so that includes both Abu Dhabi and Florida and our various other satellite operations, we're in the region now about 7,500 patients, if you include some of the new programs that we're going to be adding. So a lot of responsibility for Marc. And Marc, why are we so successful?
Oh, thank you, Lars. We are the largest cardiac surgery program on this continent, but every single patient receives individualized, very specialized care. And I think that is the key, the focus on every single patient, on his or her structural heart condition, and the team approach to treating that structural problem. Specifically on the team approach, we are a collection of heart surgeons who specialize. It's a little bit like a baseball team or a cricket team or a soccer or football team. We don't have people who play every position. We have people who play their position at the highest level in the world. So for example, whether it's aortic surgery, mitral valve surgery, heart failure, pulmonary endarterectomy, we have 2 or 3 surgeons for each one of these conditions who focus primarily on those conditions. And the combination of having the teamwork of 2 or 3 experts and the enormous volume leads inevitably to excellence and to truly the best results obtainable in the world. So as you've heard before, when a patient comes to Cleveland Clinic, you don't come to one particular doctor, you come to a team of doctors and nurses and specialists and anesthesiologists and intensivists, all focused on that individual patient. And to me, that is the key to our success, and that's why even before I came to Cleveland Clinic, I sent my family members who needed heart care to Cleveland Clinic.
Thank you, Marc. Marc touched on something that I think is very important to understand our structure. So we have an administrative structure and the department chairs who are responsible for finding great people and administering the way the departments run. But separately, we have what we call umbrellas of excellence, and that's a pairing of typically a physician and a surgeon in a group of people who have like-minded interests, and that may be 50 people or so. So we have 13 umbrellas of excellence and 50 centers under those umbrellas. And so that's a very good way of linking people with similar interests into a unit that works together to deliver superb care, make sure patients have access to us, but also do the research around it, publish jointly, and look for great leaders to hire to join the group. And so that's an important structural part of the way we run HVTI. So next, I'm going to ask Hani and Najm to talk about pediatric and congenital heart surgery. And Hani came to us from Saudi Arabia, already an international pediatric cardiac surgeon, and he has brought tremendous strength to our team. He's a superb surgeon and has delivered superb results for our group of pediatric cardiac surgeons and the pediatric congenital cardiology program. So with that introduction, Hani, what is the reason for the success now of congenital heart surgery?
Great, thank you. Thank you, Dr. Svensson. I think the biggest strength that we offer at the Cleveland Clinic is we are able to take care of fetuses with congenital heart disease up to adults with congenital heart disease. This is a spectrum that we believe that gives us the strength that many other congenital heart centers do not have, in a way that we do actually believe that taking care of the baby before the baby or the fetus is born is important by good fetal diagnosis. We have a highly specialized delivery unit that we can take care of the fetus or the baby once they come out. And we've had records of babies being in the cath lab within 20 minutes and on the OR table within 2 or 3 hours after birth that we have operated on them with great results. And from there onward, we take care of them all the way to adult life. This seamless transition of taking care of kids with congenital heart disease to adult life is unique to congenital heart centers. As you know, most of them are either taking care of children with heart disease, with congenital heart disease, or adults, and there's sometimes a break in between the care. So we're able to take care of them all their life, from birth to adult life, and give them the best care that they can have. We're very proud that our neonatal surgery have achieved great results compared to the national average, which is around mortality rate around 6 or 7%. We've been able to keep it always below 1%. Similarly, the outcome. We also believe in innovations in congenital heart surgery. Congenital heart surgery is not a very old specialty, as you know, and there are a lot of newer and more complex procedures that we have to innovate that we've been able to contribute to the community with congenital heart surgery. In addition, we believe that research and education is an integral part of a strong program. We are able to start a congenital heart surgery program starting in July, and we believe that the strength of the Cleveland Clinic is, say it again, is the teamwork, is the care of the babies right from birth until adult life. This is a seamless and truly the best care that you can have for a patient, that they know their physicians from their birth, from their parents, and they refer them all the way until their adult life.
Thank you, Hani. So two things that I really want to point out about Hani's comments, and that is that we can take care of not only pediatric congenital, but adult congenital. And as Hani mentioned, that's a seamless process. So we have a big pediatric congenital practice, but a huge adult congenital practice too. And when we count our adult congenital cases, we don't include, for example, bicuspid valves, patients with connective disorders, and Marfan's cardiomyopathy, and so on, because our numbers would just be extraordinarily high if we counted those patients also. So we don't include those, but we are able to deal with all these patients, and we have all the percutaneous options. So, for example, Samir works with our chief of pediatric congenital surgery and also adult congenital, and for example, percutaneous pulmonary valve replacements. And so we are able to leverage the strengths in our adult programs to help our pediatric programs. The other thing that Hani mentioned also is innovation. So, for example, Hani's been leading an effort of converting patients who are dependent on one ventricle but may have a smaller ventricle that's not functional, and converting patients to using both ventricles with great success. The other thing is the team has been doing some wonderful work on, for example, rerouting or de-roofing patients who have aberrant congenital inherited coronary artery disease aberrations with great success. And so the program is very broad. It has huge experience in managing these patients. So next, I'm going to ask Conrad Simpfendorfer, who leads our international team, and particularly has been a person who's been here for a long time, has seen the evolution of cardiovascular medicine and cardiac surgery at the Cleveland Clinic. He has a tremendous reputation in particularly South America, has been a wonderful advocate for our program here, and has kept in contact with our many trainees who trained here and then have become international advocates for us. So, Conrad, why do patients travel to the Cleveland Clinic for care?
Well, you know, I've been here long enough so that I have the luxury of being able to give a historical perspective how we see with pride our international presence. And this, we've done this in a couple of ways. One is by being in the leading edge of technology of medical care. We go back to the 1960s with coronary angiography with Mason-Sons, coronary bypass surgery, and the late 60s with Fred Lou, then valve repairs with Tommy Cosgrove, nowadays with coronary intervention, structural intervention with Samir. So we've done that way, and we've also done it by training people from all over the world. And I remember Mason-Sons used to say, I can go to any country in the world and I have a friend that I have trained. So, and later on we developed not only physical presence in different countries. We have it in Canada, we have it in Abu Dhabi, where else do we have it?
Soon London.
In London. We have partners all over the world, institutions that we have partnered with. And as somebody mentioned already, when we get a patient that comes for, let's say, a cardiac procedure, we can pre-plan their visit so that it's something that is seamless. Their stay is as short as possible. We already see how we provide them with excellent results. And if we run into trouble, I'm a phone call away from getting specialized in any aspect of medicine, and I'll have them seeing the patient within minutes. So that global care gives the patient the reassurance that they'll get the best care in the world. If we're a quality institution, we can be one of 200 institutions like that all over the world. If we have an international presence like the one we have, we are in a very select group of maybe 6 institutions in the world that can show that.
Super, thanks, Conrad, and that's an important historical perspective how we built on previous generations' work. All right, I'm next going to ask Suma Thomas. She's involved in managing our affiliate program, and we have both an international and a United States affiliate program. So basically, the affiliate program was set up to help institutions that had problems, usually around quality, and we have then gone in as consultants and reviewed the programs, reviewed their outcomes, and then made recommendations how to improve their quality. And that has been highly successful. For example, in the United States, we've been able to raise the various programs that have become affiliates STS star rankings in many of the operations that they do. We have never promised to increase volume, but about 70% of hospitals that we've worked with in the United States, they've also seen their volume increase. And so we have a very broad program, a consulting team that looks at all aspects. It's not just quality. We look at billing, we look at structure, we make recommendations how to reorganize structure at the institution. And so with that, let me ask Suma to talk about the affiliate program, a bit about the international consulting too.
Great. Yeah, thank you, Lars. You've heard from our experts, from the leaders from the Cleveland Clinic, about the dedication to quality and the sustainability, which is extremely important. So as Lars mentioned, we have a commitment to a mission to improve healthcare throughout the country and throughout the world. And we do this through, one of the ways is through this advisory services team that Lars mentioned. This is a team of nurses, of physicians, of quality experts, of experts throughout different specialties that work with hospitals in the United States, and we work with hospitals internationally. We do a core evaluation, like Lars mentioned. We evaluate the service line. We look for issues, opportunities, and help make recommendations. And the core, like Lars mentioned, is quality. We really want to help you improve your outcomes in every way and look across your service line for opportunities. Some of the other areas we work on are operational opportunities. How do we improve your cath lab, your turnover times? How do we think about scheduling in your outpatient areas? Some of the other things that are really important are, of course, innovation. How do we help you with innovation? So one of the things that we do is we help with, for example, helping set up a structural program. If you need help setting up a structural program or helping your program, we can do that. So overall, we have a great group of folks, but what's unique about our group is that all of the folks around this room are helping. Every doctor at the Cleveland Clinic is dedicated to helping our team and to work with hospitals across the country and across the world. Let's tell you a little bit about our affiliates and our alliance partners. These are longer-term relationships that we have with hospitals across the country, where we work on providing advice on quality, on operations. We provide intellectual property. We do second opinion consults. You may get a second opinion from Marc Gillinov, from Leslie Cho, from all of the folks in this room and everybody throughout the Institute. So these are just some of the services we provide through affiliations and alliances. We really want to just emphasize that collaboration, like everyone said in this room, is extremely important. Collaboration and teamwork, it's more important than ever in this time of COVID. We've been able to do a lot of our work virtually, as some folks have talked about as well. And so we really welcome you to contact us if you're interested in working with us in the future.
Thank you, Suma. So as Suma emphasized, this is a very strong consulting team. Everybody is master's level, MBAs, nursing, various other health categories, MPH, etc. And so this is a very strong group from a consulting point of view and giving the best advice we believe in the United States. And it's not just theoretical advice. This is practical advice, how we do it. And so it's a very valuable team for those of you who are interested. So let me ask Nick Davalla next to talk about quality boards and how we manage some of the quality aspects. So Nick is our project lead on new efforts and also new projects, but also maintaining what we do well. And so one of the challenges for us is as we acquire more and more hospitals, and we continue to acquire new hospitals. For example, we just joined up with Mercy Hospital, which is about just over an hour south of us, among our many regional hospitals. We want to standardize care so it's the same as much as possible on main campus as in our regional hospitals. Now, obviously, main campus takes the most complex operations, and if you take, for example, Marc Gillenov's department, some 65% of operations cannot be categorized by the Society of Thoracic Surgery operative categories because they're too complex. And so the more complex cases come to main campus, and we encourage our surgeons and cardiologists to send the more complex cases here. However, for straightforward cases and, for example, whether it's PCI, cardiac surgery, thoracic surgery, vascular surgery, we work with our other hospitals, including Florida, and now rolling out in London, offering them our various protocols and processes and similar structures that we use to manage patients. For example, our echocardiography database is being implemented in London so that we have seamless visualization across the system of quality. So Nick has been given the task of overseeing the 12 quality boards we have. So these are physicians who are in a quality board to oversee quality for all our hospitals, and they work with the leadership in each hospital. Our hospital presidents are all aligned on this and are very much involved in making sure we deliver the best possible care across the whole system. And Tommy Mahowick, our CEO, has emphasized that we have this symptomless, this same quality across the system. So with that introduction, Nick, tell us how you work.
Sure. Thank you, Dr. Svensson. Well, I think the way that we get things done at the clinic really starts with teamwork, and pulling together the data we need isn't just one person pulling that data together. We need a whole team of quality data registry folks, because if we're going to do any quality outcome work, we need to know how we're performing and then identify where we have those opportunities to improve. And what I've really witnessed since I've joined the Heart, Vascular, Thoracic Institute is that ability to work as a team with physician leadership, nursing leadership, and really driving those outcomes. So while my group is pulling together the data, we're not really responsible for the clinical care, but it's providing the information to those who are, and then helping ensure that we have those processes in place. I had the opportunity to be in the cath lab a couple weeks ago and saw the timeout huddle prior to a patient procedure and witnessed how Dr. Bezier ran through that, and it was by the book, making sure that everyone in the room knew all the components of the case and that the patient was aware. And seeing those processes happening within that team, and then we see those outcomes in the data we share, and making sure that we can take those types of processes, see what the opportunities are in that data, and then share those. I see we have questions in the chat, ensuring that we share those processes across our system so that we can get the same outcomes, whether you're in Florida, Northeast Ohio, or elsewhere.
Thank you, Nick. So one of the things that Nick touched on is, I think, something that certainly was unique here at the Cleveland Clinic for many years now has been adopted more widely. It is something that's pushed by CMS now also, and that is what we call a huddle. And so at the beginning of any procedure that is done, not only in the operating rooms, but in ICU, on the floors, there is a huddle where there's a discussion among all the so-called caregivers about what the procedure is going to be, making sure everything's available and the appropriate consent, etc., has been done. And in the operating rooms, we have a checklist for cardiac surgery, we have one for thoracic, we have one for vascular, hybrid rooms, etc. And we work through that with our nurses, so the lead nurse in the operating room goes through that. And if anesthesia is involved, then they are also part of this process, and we then go through that. And that is something that we have across the whole system to try and standardize care. So one of the questions was, how do we manage our geographic footprint and satellites, make sure we have a collaborative culture? So that's one of the answers, as Nick was mentioning, about how we watch quality. But the other thing we think is very important is that people spend time at main campus to get a feel for the culture, and so they understand the way we do things. And as we acquire hospitals, we try and, over time, build that culture into the institution. Now, let me take it, for example, Akron General, which was an affiliate program for HVTI first before it became one of our hospitals. And we have progressively introduced our protocols, worked with leadership. The hospital president is one of our former presidents here at one of the regional hospitals more close to us at Hillcrest. And so we work very closely with the hospital presidents to develop protocols, have the right people in place, work on culture, and the same structure that we have at main campus that has been so successful for us. So another question we have here is, what is the future of heart surgery in adults and children? Good question. We could spend a long time talking about both how disease has changed, certainly in the United States, with obesity and diabetes being a big factor, how the structure of heart care is changing in the United States. In the United States, the big change is more to government-funded healthcare. And then the obvious thing is there are always new innovations that are coming into play. And we can ask various members of the panel here about what they see as far as those three aspects. Leslie is an expert on disease processes, diabetes, prevention, and so on. So we'll ask her about that. We'll ask Samir about new innovations in structural heart disease. But to start off, let me ask Hani, what is going to change in pediatric congenital heart care over the next 10 years? What do you see is going to change, other than us being one of the leading institutions in the United States?
As you know, the better we take care of kids with heart disease, they're going to become adults with heart disease. And this is a population today are bigger than children with congenital heart disease. And that is a specialty that is growing, and it's not going to stop, and it's going to continue to grow. And the reality is, I believe that adults with congenital heart disease programs have to be subspecialized and concentrated in areas, because they present a different group of patients that needs to be addressed. That is, they have multiple surgeries before they come in with abnormal physiologies, and they need experts such as what we have here to deal with all the others. So they have acquired disease as well as congenital disease, because when they get older, they will have also the acquired heart disease that can be seen in addition to other organ dysfunction. But I do believe also that congenital heart disease is going to be transformed with newer operation, newer interventions that we do more in pediatrics that sit them hopefully in a better situation in their adult life, and maybe decrease the number of operations and possibly have them live longer. We've seen kids that during my training we tried to even handle them. They just never survived. And now we probably operate on 99.9% of kids with congenital heart disease, whatever the spectrum is, except that they have if they are born with multiple congenital anomalies. So early diagnosis, this is important. I think fetal, one of the areas that is still lacking is diagnosis of fetal heart disease. And we still get only 60-70% of our kids are born with a diagnosis. Others are born then got diagnosed. And I think we optimize that, we can optimize their outcome. So there are multiple levels of where we can improve on congenital heart disease from birth all the way to the adult life.
So just to add to what you were saying, Hani, one of the things that I've seen Hani using more and more of is 3D printing and also MRI 3D imaging to understand complex defects in patients, and then building all sorts of fancy baffles and pathways for blood to flow to make the hearts repairable and more functional in kids. And as Hani mentioned, we are going to see a huge population of adults now with congenital heart disease that's being corrected. Now, unfortunately, a lot of those patients, about 2/3 of them, will have electrophysiological problems over time. And so our electrophysiology team is is seeing more and more of those patients and managing them very successfully with the new devices that we have in electrophysiology. I think that's been one of the great successes in the last 20 years is electrophysiological management of these patients. I'm going to ask Marc Gillinov also to give some projections of what he's seeing in the future of cardiac surgery. Obviously, we are doing more and more less invasive procedures. It sounds like a usual terminology, more of less. But Marc's really been a superb leader in our robotic program. What other areas do you think we're going to do less invasive procedures, or what are your thoughts about the future of cardiac surgery, particularly as we deal more with patients with TAVRs or patients who've had multiple operations and now need valves, cabbages, aortas, stent grafting? What are your thoughts?
You just answered the question the way I would. At the extremes, we're going to see more less invasive surgical approaches like robotics for a larger group of people, and then the most complex cases, the people who've had 4 and 5 different operations and maybe elsewhere we're deemed to have no option. We are developing options with our teams, with our expertise, and we are really pushing the limits at the extremes for even older patients who need a multiple reoperative strategy. We can put it together and oftentimes deal with some of the problems structurally in the cath lab with Dr. Kapadia and his team, and then go to the operating room. We can use the hybrid operating room and do multiple procedures in one setting. So I think we're going to see less invasive options for more people and new options for the most complex people who previously didn't have an option. Now we can treat them.
What about the end-stage patients? So patients end-stage heart disease, heart failure, end-stage lung disease. As you know, we've had a lot of success there. What are your thoughts about that?
We'd love it if transplants could grow, but they're limited, of course, everywhere, including here by organ availability. Nonetheless, we've done now this year, we had 2,000 hearts and 2,000 lung transplants with excellent results. But I think where you're going is what sort of mechanical lung support and heart support is going to be available. And we've got teams on the frontiers of both mechanical circulatory support and mechanical pulmonary support. Right now, we're probably a little bit further with the heart and supporting the heart with extracorporeal sorts of devices and intracorporeal. But I think we'll see better LVADs, smaller LVADs, total artificial heart. We do those and we're expanding. And our pediatrics team has a very large grant to develop a new mechanical circulatory support for infants. So that's been a long-term project, and I think we'll see it come to fruition.
Yeah, I agree with you. There's been a lot of breakthroughs now in left ventricular assist devices. The total replacement heart has always been a challenge, but as Marc mentioned, our research team is making progress on that, and particularly in the pediatric population. So great outcomes on that. The other thing, as Marc touched on, is the problem of getting organs. And one of our residents who then got his PhD while he was a resident, is now on our staff, he worked on ways to resuscitate lungs that appeared not to be ideal from a transplantation point of view. And now about 20% of our lung transplants, the lungs have been put on so-called lung in a box. So this is a perfusion resuscitation of the lungs. And that has contributed hugely to our success in the lung transplantation program. And a similar idea is occurring also with heart transplants. The idea of resuscitating hearts that have stopped and then seeing how they perform and broadening the number of potential donors. Our Florida site at Western has been very successful in growing heart transplant the program down there. And so this last year, 2020, despite COVID, they did 47 heart transplants. And part of it is obviously related to organ availability. But that's been a great success of Western program. And the result is that we can list patients both here at main campus and in Western Florida for heart transplants and get patients transplanted quicker. So getting back to what we started off on, Leslie, how's disease going to change? How are we going to change managing patients and preventing them from having to need procedures?
Yeah, it's a big societal problem because if you're an African American born in the U.S. or Hispanic born in the U.S. In 2021, you have over 50% chance of developing diabetes, which is astounding. And we all know diabetes causes coronary artery disease, increases heart failure, so it really is a problem. And I think the growing wealth of the third world countries will bring that kind of first world problems like obesity, hypertension, hyperlipidemia to front and center. Pollution causes coronary artery disease. So there is no end to the coronary heart disease out there. But I think the important thing is prevention, as you said, and societal ways to prevent by lowering sodium intake, but also really understanding food quality and how to do that in a societal level is really important. But in a smaller scale, Heart and Vascular Institute, under your leadership and under Samir's leadership, has been insightful enough to open resistant hypertension clinic within cardiology, has opened cardiometabolic clinic to join that important disease state, diabetes and CAD, diabetes and heart failure, resistant hypertension and stroke, resistant hypertension and heart failure and CAD, all in one center. So I think really the future for improving prevention or preventing heart disease is really collaborative and thinking broad and multidisciplinary.
Well, thanks, Leslie, for those comments. For those who are listening internationally, and this was set up as an international meeting, there's a very important paper that was just published in JAMA a few weeks ago, looking at the burden of it's JAMA Cardiology, on the burden of cardiovascular disease around the world. And in many countries, emerging countries, the rate of coronary artery disease has doubled and some even tripled. And I remember when I was doing cardiology, when the first black African, had a heart attack in Johannesburg, and we all had thought that that would not occur. But it was a result of smoking and Western diet. And as Leslie also mentioned, the particle 25 pollution is a big factor also in increasing coronary artery disease. I've talked to some of my friends in South Africa, and they're doing a ton of coronary artery bypass surgery now in the African population, which we never used to see as diets have become westernized, bad habits have taken hold in the diets, etc., and apart from pollution. So this is a challenge that many of you, I'm sure, are already experiencing. I see data from India and China, Nigeria, showing that this is an increasing complex problem. And for example, we're working in the Middle East with some national health groups over how do we address some of these issues and how can we help them in better managing their population and prevention. And for example, at one time, Stockholm, Sweden had the highest rate of coronary artery disease in the world, together with Glasgow in Scotland. And there was a big push to improve the health of the population with a lot of success. So let me get back now to Samir about where do you see future advances in structural heart disease. Obviously, TAVR and mitral valve clips were major breakthroughs. Are there any major other breakthroughs coming, or is it going to now be incremental improvements in structural heart disease?
So thank you again. I think the most important, if you step back, that why structural or minimal invasive things are working is that there are two things that surgery does very well. One is to visualize that what you are working on, and then you have precision of doing the repair of whatever you want to do. With the structural intervention, the imaging has improved to a level, and it is improving. It has some work cut out for it, but the imaging is getting to a level where we are able to visualize the intricate details of the anatomy in a beating heart, which is, if it improves even further, our precisions will be better. And the instrumentation is also getting better because miniaturized instruments, very precise motions are possible. And so the next step is to develop and think about new methods to do exactly what you would do with an open surgery. The challenge or the beauty is that we have to collaborate as cardiologists and cardiac surgeons together. We are finding out very fast, and this is what we do best in Cleveland Clinic, is that, as Marc pointed out, we have two spectrums of diseases. So one, people, of course, are very young and they do not want to have invasive procedures, and we want to do minimally invasive procedures. And there we require some kind of a lifetime management because those diseases will progress over time. So we need to have surgical options such that they are done in a very innovative, minimally invasive way that can complement future interventions transcatheter-wise. And then we are finding patients who are very, very sick, very old, and they want to have structural interventions or surgery. And surgical expertise for this kind of patients is getting lower and lower in the world because there are not that many good surgeons who can operate on very sick people. And so in the future, what I see is that we will need very experienced surgeons who can operate on the people that have had structural interventions or procedures. Operations are going to be super complex, and the expectations of the patient and the family would be such that, okay, well, this is going to be possible because of the advancement. So this is the challenge that we will face in the future as we go forward at the lower end, to find a very nice minimally invasive surgery such that it can complement structural intervention in the future, or find some solution for very sick people who have multiple surgeries and multiple percutaneous operations and now need a very experienced surgeon to be able to handle this kind of very complex situations.
Very good point, Samir. And the big centers, and it's interesting now with the valve guidelines, they even recognize and put criteria for valve centers of excellence. This is going to be an important part of the future, that the big institutions are going to have to deliver complex care, whether that's from a heart surgery point of view, structural heart, or whatever. It's a team approach, multiple people involved in the care of patients. We have a question about, does philanthropy keep you number one? Philanthropy is very important. What I would say is we spend between $20 and $25 million a year on research. The bulk of that is funded by companies, but particularly when we're looking at our outcomes research, that is funded approximately half from philanthropy and half from operations. In other words, if this is particularly related to quality, then we've funded out of operations. If it is more innovation, looking at new ways of managing patients that may not be directly quality related, then we fund that out of philanthropy. So philanthropy is a very important part of our mission. The philanthropy also funds a lot of innovation. So, for example, devices, and we have a lot of so-called chairs. So these are sort of equivalent to a professor's chair, and we then allocate funding to the person who holds the chair to do research. And so that is another way that we fund research. Now, if there's special projects, we will take money from philanthropy to support that too. So it's a very important part of a structure. In the last couple of minutes, I'm just going to go around and ask people for some final comments and thoughts. And we'll start with you, Conrad.
Well, I'm a strong believer of person-to-person relationship with professional colleagues or with patients. But having been through this year of COVID, I think I've learned the value of virtual visits. And I'm just thinking, we do Zoom meetings, professional meetings, and they work out pretty well. But I see a great potential to keep in touch with our international patients. And I think that's one aspect that we need to develop. We save them trips, we stay in contact with them, not just once a year, but maybe more frequent. So I think we should look into that.
Good point. Marc?
I remain impressed by how big we are, yet how individualized we are. That each person who comes here feels that he or she was our sole focus of attention. And with all the expertise and the size of this building, that's nearly 1 million square feet, we bring it down in every single instance to an individual level.
Good point, yeah. So 1 million square feet, 500 odd beds, 120 ICU beds, although we've just increased our number by another 16. Hani?
We couldn't close this session without actually asking you, Dr. Svensson. You've led this department to new levels, and you've created such a gap between us, even the second position on this. We need to have our audience hear, how does it lead? What's your vision and leadership for such a large department? And where do you see the pressure points that is coming on with this? You've made an amazing progress in the last few years, and it's going to be very difficult to be matched.
Well, Hani, that's kind of you to say so, but I learned very young when I had a leadership position. A leader is much more dependent on his teams and the people under him than the teams under them are their leader. So it's the great work everybody does. It's just fantastic that as a great team, as a great family, we work so well together. And that to me is the key. Suma?
Yeah, so I've been at the clinic for 7 years, and what I've been struck with the entire time I've been here is not only the excellence throughout the departments, is the sustainability of all of it. And I think that's the key piece that we really need to focus on, and that's how other hospitals can also get to. Most hospitals are doing great, but how do you sustain it? You sustain it because you have that culture of change, and you're always willing to make things better. And that's what I'm struck by. I work with amazing cardiologists and surgeons every day, but every single one of them is dedicated to improving and getting better and innovating. So that's what I think it's all about for the Cleveland Clinic.
I agree. We have this mantra, just to sort of emphasize what Suma was saying, that we must change and innovate to stay ahead. We have to preserve our great practice and be obsessive about making sure our physicians are happy in the work they do. We educate future leaders, and that this is the best place to work, the best teams to work. And then we are paranoid about making sure that we have unparalleled, unbeaten, untouchable is the term I use for that quality of care for our patients. And that's not only in outcomes and mortality rates, but also recovery to fulfilling lives and also valued care that they experience when they're here. In other words, they have a great experience and they become our greatest advocates. Leslie?
I think the one really important thing that we do is that we take chances on sort of novel things like AFib ablation. When it first came, everybody thought it was crazy that we would take our chances on that. But then we did, and of course now we have the largest PVI center in the world. And also we give our new staff time to grow. So I remember when Mass Hannah, one of our heart failure staff, wanted to focus on amyloid and heart disease, and amyloid heart failure. And it was such a rare thing. And now we know so much more. Now there's a drug to treat that. But the fact that we give them time, like a room to grow and room to innovate, I think makes us great.
Well, thank you. That's a very important point that you brought up. And for example, with AFib, Suma Wasni, our chair or director of the section of electrophysiology, just had a paper published in New England Medicine. It was extensively reviewed and quoted, showing that early ablation in patients with atrial fibrillation, at least in this study, shows better benefit than medication attempts at control of atrial fibrillation. And then together with another paper in New England Medicine, that's probably going to change clinical practice. Will take some time for it to get into the guidelines, but that's a radical change. And Cleveland Clinic has been at the forefront of changing healthcare many, many times, and we'll continue to work on doing that. So, yeah.
So I think the most important thing I find is that everybody that works here enjoys it. We do a lot of complicated things, we do a lot of stressful things, but we are not really stressed. We really enjoy taking care of these complicated things. And this is a very unique group of people, unique opportunity. I enjoy coming to work every day, and most of us enjoy to come to work. We spend more time at work than at home, but we do not regret that. And we have great friends and colleagues that we work with. So the entire experience is of gratitude. It's fun. We feel that we are lucky that we are able to work in Cleveland Clinic. No one is indispensable, but everybody is extremely useful to the organization. So this is a very unique group of people that we have opportunity to work with, and I'm really thankful for that.
Well, Samir, as they say in the Houses of Parliament at Westminster, when the British are having their debates, when you agree with somebody, it's here. It's a great point. Nick, some final words?
So I think what I've been most impressed by in my time within the Institute is while we are a high-performing, highly reliable group, we have a dedication of culture around quality and continuous improvement. And what can we do to continue to get better? So we're doing very, very well. We're not satisfied with that, and we want to keep getting better.
Very important point. We're always looking to get better. So thank you for joining this session. We have recorded it, and so we'll plan to post this also on YouTube for you to share with friends if you wish to. And thank you for your participation. Thank you for the panel for being part of this. Very much appreciate your time. Valuable work, as many of you are dressed in your scrubs and ready to go to procedures. Thank you.
Thank you.